All right, so two cases of complex IVC filter retrievals. The first one is a 53-year-old gentleman who has provoked DVT and PE in December of 2015, but he had to undergo surgery for multinodular goiter, so he had to interrupt anticoagulation. Thus, an IVC filter was placed, and this venogram is from the time of the IVC filter placement. On day 18, he was referred to the cath lab for IVC filter retrieval as he was able to tolerate anticoagulation. And we attempted to retrieve the filter by using the standard techniques, using a 9 French sheath with different types of snares. However, as you can see here, the filter is tilted to the left, and we were unable to hook the snare to the actual hook of the filter. And we tried the curved catheter to try to direct the snare to the hook, but that was unsuccessful. So we brought him back for more advanced techniques. We had accessed the femoral vein and tried balloon-assisted technique to try to realign the filter and try to retrieve it, but that was unsuccessful. We tried larger balloons and tried to do venoplasty between the filter and the IVC, and that was not successful either. So at that point, we tried the cone retrieval system, and the cone was able to capture the side of the filter, but the filter was too bulky to go into the sheath, and this is an 11 French sheath. What happened is that the hook of the filter would hit the distal end of the sheath. So what we did is that we cut this sheath, which is an 11 French unbraided sheath, we cut it diagonally to increase the perimeter of the sheath and the surface area. So the cone was able to hook to the side of the filter, and we were able to retrieve the entirety of the filter using this technique. And this is just a gross specimen. You can see that this is the sheath, and it's cut diagonally. There is more perimeter, and the surface area is larger, so we were able to capture the whole filter. The second case is a 61-year-old gentleman who had provoked DVT-PE. An IVC filter had to be placed because he had an ischemic stroke with hemorrhagic transformation, stopping anticoagulation. Then 3 years later, he was referred to the cath lab for IVC filter retrieval. And this is the cavography that was done on the day of retrieval 3 years later. And you can see that the filter is again tilted to the left of the IVC. We attempted standard techniques, but that failed. We attempted using different snares. We could never capture the hook of the filter. Then we proceeded with the wire loop technique, where we used a reverse curve catheter with a hydrophilic wire. In this case, it was a soft-angled glide wire that was retrieved back, snared back to the sheath, and this is an 11 French sheath. And we pulled on the wire with both ends, and we were able to at least realign the filter and retrieve most of the filter except for the last 1 to 2 centimeters, where they were still stuck on the IVC wall. So at that point, we determined that we needed a dissection technique. So we replaced the existing sheath over the loop of the wire with a 14 French sheath, and we advanced a 12 French excimer laser. And we used thermal ablation to retrieve the filter, and that was successful to retrieve it without any complications. So IVC filters have been increasingly being used since their inception in 1973 by Greenfield. In fact, IVC interruption has been in place since the late 1800s. The retrievable IVC filters were first FDA approved in 2003. The retrieval of IVC filters is very low, with a mean retrieval rate of 34%, and in cancer patients this goes to less than 2%. The majority of IVC filters, if retrieved within a short period of time, they can be retrieved using standard techniques in up to 90% of the cases. But with prolonged dwell times, advanced techniques need to be used in up to 60% of the cases. And one analysis defined prolonged dwell time is if it's more than 7 months. If it's less than 7 months, most of the times the filter can be retrieved easily with standard techniques in most of the cases. However, if it's more than 7 months, which is the cutoff point, you would probably need advanced techniques in more than 60% of the cases. And the most common reason for difficult retrieval is tilting of the filter, or if the hook of the filter is embedded in the IVC wall. This is one algorithm that was proposed to try to retrieve a filter. If the filter is not embedded, then a standard retrieval technique is recommended as a first line. If it is embedded, or if this fails, then advanced techniques are recommended. Starting with a wire loop technique. If that fails, then a balloon-assisted technique, and if that fails, then a dissection technique is recommended, either by using thermal laser or by using a rigid endobronchial forceps to try to capture the filter and retrieve it. Going to advanced techniques, we should bear in mind that there are some complications of advanced technique retrievals, such as IVC injury, including breach of the wall, IVC stenosis, or pseudoaneurysm, or filter fragmentation and embolization of its components. Now, with experienced operators, the reported complication rate was less than 5%. On the other hand, there are complications of unretrieved filters, including increased risk of lower extremity DVT that can happen based on the PREPIC 1 trial in up to 30% of the cases. But in the modern era, it's up to 5% of the cases. IVC thrombosis can happen in up to 4% of the cases. Penetration of the filter legs beyond the IVC wall with visceral injury, less than 1% of the cases, and filter migration, which is actually surprisingly reported in 20% of the cases, especially cranially. So in conclusion, patients with retrievable IVC filters should be followed closely to arrange prompt retrieval. And in complex cases, the risk of using advanced retrieval techniques should be weighed against the risks of leaving the filter permanently indwelling. Thank you.
Great examples of some difficult filter retrieval. I think that the fact that you had to advance to the laser in that other case speaks to the difficulty of removal in some of these cases. I am intrigued by the cutting the sheath at an angle. I think that's a great idea. Was it difficult to reinsert the sheath once you cut it at that angle, or
how'd you
get
it back through?
Yeah.
It was not. We used the.
We went through a 16 French short sheath.
We put the
so you put it
larger
through
sheath first, and
okay.
through the sheath.
Gotcha.
Yeah. And to cut the sheath, it has to be unbraided. That's a good point to make, because cooked sheaths, for instance, are braided. If you are going to modify a sheath, it needs to be unbraided. That would make it easier to modify.
The other thing you can do is you can put like a mother and daughter catheter in it, or dilator from another sheath, and advance it if you don't want to make a bigger hole in the neck.
So sometimes the tip of the filter, the hook, has already penetrated through the IVC, and you really can't tell that.
Right.
It's very hard. You can see just a little bit, 2-3 millimeter beyond the point. And so when you're doing this, are you re-imaging them before to make sure you're not going to tear that IVC?
So that's a good point. So some operators, or in the literature, some advocate, if it's been there for a long time, especially more than 7 months, to get a CT venography. To see if the IVC filter is penetrating the IVC wall, is it penetrating to the viscera or not. In our practice, we just bring them to the cath lab and do a cavography basically and see. And if we don't see it, at least we know that it's not grade 3 penetration. It's not going to a viscera. It may be going through the wall, but it's probably not going beyond that. And if we see that it's going out of the wall, then we stop and get a CT venography to further evaluate.
And how do you manage those patients going through the wall but not reaching the grade 3 level penetration?
Probably the same way, because it's a very small penetration, and it's probably all healed and scarred.
If the legs are penetrating, it's not a problem. If the tip is penetrating,
it's the hook,
it's a little bit more of a problem.
Yes.
So in the literature, what they describe is to use the forceps to try to get it exposed, and then realign it, then retrieve it.
Yes. This could be highly risky once you're
Right.
fibrotic around the thing.
Right.
Just trying to tear this stuff.
And surprisingly, the IVC perforation rate was less than 5%, even with using a forceps to expose the hook and then realign it, then retrieve it.
I had a case actually that I've been following now for about a year and a half with CTs, and he did not want to have any more treatment. And we measured the hook that penetrated through the IVC to the vertebra, to the aorta, to the actual wall of the vein. You can see it very nicely on CT. And serial CTs have shown absolutely stable position, has not migrated beyond that point. And so we keep following him in a very, very conservative manner.
I don't know if you need to do that
Yeah.
because the IVC filter, the tip comes. This is the tip that can penetrate, but then the legs come out. And
They will anchor.
I mean, it will anchor. There's no way the legs are going to be compressed and go out. So I don't think you need to seriously keep.
We don't have to. Yeah, I mean, we just did that in the. He has had already 2 CTs, so I don't know whether I keep repeating them or not. I think he's fine.
Yeah,
The,
he probably
the legs will
needs
penetrate,
coagulation
and
though.
I've seen the legs. I've seen GI bleeding, perforation into the viscous.
We had a patient, pregnant lady who one of the legs penetrated the uterus. I mean,
Oh.
the legs can penetrate.
That's a problem.
Can be a big problem.
I think the key thing with IVCs is don't put them in unless they have to, and then if you put it in,
Take it out.
it is your responsibility to take it
responsibility,
out.
absolutely.
You got to make certain that you have a way of following those patients.
Absolutely.
Well, great. Thank you very much.
All right, thank you.
Well, I think that was a really fantastic group of presentations. We are going to commiserate briefly here for a moment regarding the overall winner. I do have finalist certificates for everyone as well. So if you'll just hold tight, we'll step aside for a second. Shall we step out for a second? Okay. Not do it right in front of everyone watching with the mics on. We'll be very fast. Okay. Well, again, I want to emphasize what a fantastic job everyone did. That was a really great session, I think. Lots to learn from complex venous and arterial cases. We have reached a consensus. I think that we really enjoyed every single case, and it's difficult to choose one. But we specified only one winner here. And we've decided that will be Tallia Rousan for the last case. I do have a check here that we will make out to you.
Which bar are you going to? All right.
Here you go. If you hang out right afterwards, I'll get you the check.
Thank you so much. Thank you.
And I would also like to ask every other finalist to come up as well. We do have finalist certificates for you. I really appreciate the hard work that everyone put in.
Yeah, thank you, everyone. These cases are great to see, and I think we've had people walk by us and just say thanks so much for doing cases, and compliments to Aaron and everyone too, because I think cases where we learn the most, at least for me. So great job.
Great job. Yeah,
Awesome.
appreciate it.